Welcome to the Research Works podcast, live from the European Academy of Childhood Disability Conference 2024 in Bruges, Belgium. Join us for interviews with keynote speakers, world-renowned researchers and clinicians, and behind-the-scenes stories from one of the great paediatric conferences in the world.
Well, hello everyone. It is now the final day, day 3 of the EACD conference, and I'm catching up with what I'll call an old friend of mine. We met back in season 1, Dr Magnus Pa from the University of Gothenburg in Sweden and the Queen Sylvia Children's Hospital in Gothenburg. Hello, Magnus.
Hello. Very nice to see you.
I know, and it's very, very nice. And the last time we spoke a lot about your work that you're doing for your PhD, and it's so incredibly interesting. And you've come to this conference to present your paper, which was titled Lower Intellectual Level Over Time is Common in Children with Cerebral Palsy.
Right.
Yes, a very interesting topic that is so useful for so many clinicians and families. How about before we get into some questions that I have for you, can you give us a bit of an overview summary about what you presented?
Actually, it's a further work, a follow-up from my PhD.
Yes.
I have the same cohort of 264 children. And for my PhD, we collected all the cognitive assessments. And now we have continued follow them up to an age of at least 17.
Wow.
So we thought we had a good possibility to longitudinal.
Yes.
Looking back, of course.
Yes.
And because our clinical experience is that many children with cerebral palsy actually they drop or they reach the top before, and they maybe start at a normal intellectual level and then come down to a mild intellectual disability or even lower.
Wow.
They are not actually deteriorating, but they stop developing.
Yes.
So we thought we had a good possibility to look back.
Right.
So we had the children who had at least 2 assessments during the development and see what happened from the first to the last. And there were 171 children.
Wow.
And what we found was actually more than I thought. More than half of them dropped in intellectual level. Then we used 6 levels from normal down to profound intellectual disability. And more than 50% dropped. And then we try to look at factors connected with that. Not actually causal factors, but markers to whom to assess more thoroughly. And then we found epilepsy and communication impairment as what I see as markers.
Wow. It's really interesting, isn't it, when you look at this data, which is such rich data. We spoke about that last time. Yeah. The register, and we had Professor Kate hlman here as well, talking about the register. Yeah. It provides so much crucial information. And the theme of the conference, when I've been speaking to a lot of people, is, being more innovative of how we use data, how we look at data and how we can learn from these real-life scenarios. Can you go through with us just to give us a bit of a snapshot? And I know it's a relatively complicated process, but when it comes to intellectual disability, how is that assessed in this population of children with cerebral palsy?
For most children, the way we used to assess them with Wechsler scales, because most children are not severely impaired.
Okay, yeah.
And you could do the ordinary tests without adaptations.
Okay.
But of course, for the lower, you have to adapt them in any way. The way of pointing, the way of...
Sure.
You couldn't actually always do all the tests.
Okay.
So you have to use your clinical knowledge and experience as well.
Okay, yeah.
And I'm very happy to work together with skilled and experienced professionals.
Yeah.
And also, of course, on the lower range, we have those developmental scales like Griffith and Bailey and so.
Okay. So that was the data that was put into the register that you were able to look at?
There was actually not always put in the register. It was a part of my PhD when I
see. Okay.
I collected more data than in the register.
Okay. Because I was going to say that was it's pretty incredible if a register has that information already on there. Are you hoping this is something that you can continue to track, to put in the register as a more routine way of collecting data?
No, I don't think that is too much for a register, actually.
Yeah, okay.
I think the register is the basis for which children have CP and other problems, classifications, functions, and impairments as well.
Yeah. And can you talk us through a little bit about the levels, the 6 levels that you were describing there?
Yeah.
How we describe that?
We use the EACD level. We start at the normal intellectual level, that is about 85. And then the borderline intellectual functioning, that's 70 to 85.
Yeah.
Of course, the numbers are a bit approximately
the
lower count.
Yes.
And then the 4 levels of intellectual disability: mild, moderate, severe, and profound.
Right.
But we use the DSM-5 terminology.
Yeah, sure. And I guess that's what people understand and they know about that.
Yeah.
And then in terms of the children that were included in your study, you said, 100 and... How many was that?
171.
171, which is a really decent number.
So it was actually 264 from the beginning, but 93 had just none or just one assessment, so we had to put them away. But they were mainly at the normal range.
Right, okay.
Or at the lowest.
Oh, I see, okay. And these children with cerebral palsy, in terms of their functioning level, do you recall what level they were functioning within GMFCS levels, or was it quite wide-ranging?
Yes,
yeah,
all levels.
Wow, okay.
Because it's a population-based group from the beginning.
Yeah, that's right. So what you actually found, which is very intriguing, you called it markers.
Yeah.
Can you talk us through about what that means and what that result was?
Well, I see this as a first step in exploration, how it is.
Yes.
Because when I have tried to find out what we know about it, it's mostly cross-sectional data.
Yes.
There was some presentations yesterday about cross-section. You could see that the median IQ dropped by time, but we have the possibility to actually follow the single child.
Yes.
And, well, it confirmed our clinical experience. So finding risk factors is a way, I think, of helping the clinicians to know what to focus more on.
Yes.
And also it gives a possibility to think further about etiology and if we could do anything about it.
Yeah, that's right.
So it was we tried to see what we could find association or factors.
Yes.
And most of them we didn't find any association, like sex, gestational age, CP type, GMFCS, MAX, and so.
Right.
Vision, even autism at age, there were no clear connection.
Okay.
Maybe there are connections with other things. We don't know. It's just this group we have.
Yeah.
But I'm not surprised about epilepsy.
Yeah.
Because that's mainly, for me, a marker of a more severe brain lesion that actually affects the gray matter.
Yes.
The cortex.
Yes.
And that you need for your cognition, of course.
Yes, that's right.
And in the communication, I've learned from my speech and language therapists that children who actually in the beginning have a good impressive language, but a low expression.
Yes.
They tend to stop increasing their impressive language when growing up if they're not getting a way of expressing themselves.
I see.
It's actually a give and take in that development. So for me, that was not so strange.
Yes, yeah.
Because you have to express yourself, you have to understand.
Yes.
It's a dialogue.
There's a cognitive process, involved with all of that, And the other one he did have as well was max level as well, that was associated.
Yes, but in the beginning, when we divided it more roughly, we could see a association with fine motor function.
Okay.
But then when we divided it further into the 6 levels.
Yes.
We couldn't find that
I
association.
see.
So that's in the abstract,
Yeah.
but it's not in the presentation.
Right. Oh, that's really interesting. That's really interesting. So Magnus, I mean, I always find I'm in such a privileged position to be able to speak with experts like you. So I get to ask so many questions. And you are mainly a clinician, aren't you? You're a neurologist that works clinically. So you probably see a lot of this. What I noticed, well, I guess the thing that you said was very clear as well when it came to epilepsy. That didn't surprise you because of the level of brain lesion. One of the things that does come up clinically when I work with a lot of families too is the concern that families have with the amount of seizures children might have over time. And there seems to be, like, I'm not an expert in the area, but there seems to be this trend where it can increase sometimes as they're trying to figure out the medication. And they find that when things kind of settle, they feel like intellectually or communication-wise, they're not as where they were before all of that. Is that what you see as well? And what do you think that means? Because I feel like that's always a question. I don't know what to say about that.
Yeah. I don't know what I dare to say about it, because there are so many levels in that you don't know.
Sure.
From the beginning, you have the brain lesion, and it differs between children. Then you have the amount of seizures, if it's treated successfully or not.
Yes.
Then you have the medication that can affect you as well.
Yeah, alertness and
So as I said, as far as we've got now, I think about it as a marker, not a cause of it, but maybe there are both. I don't know, actually.
Yeah. It's a very complex area, isn't
it?
And I find that which is why this work is so crucial. It helps us to start to point in a direction of trying to understand where things are. But I do see that a lot, or sometimes when children might go through this whole phase of exploring different medications, I hear parents often talk a lot about regression, like, have they regressed? What do you say to that when you hear that in the clinic, in the clinic room?
I try to listen and try to understand what they say.
Yeah.
If there are certain medicines, certain events or something, you could, of course, have a severe seizure, admitted to hospital to stop it, and so of course that will affect you.
Yeah, sure.
But it also, sometimes I think we treat too heavy. And it's always a balance between how much you should medicate.
Yes.
I've learned from my seniors that the treatment should not be worse than the disorder.
Yeah. Everything's in balance.
But it's actually really hard. In some children. And these are the ones we are talking about. But in most, I think there is quite good possibilities to treat.
Great. And
we have also seen that epilepsy is not always following you up in adult life. You could. It's quite a good chance of stopping medicine for some children.
Some children,
But it's these are individuals and individual
so complicated.
problems.
Yeah, that's right. I understand that. I understand.
And that is always one of my main messages.
Yes.
Every single child should have their...
And take the time to hear and understand, isn't it? Yeah. We spoke a little bit earlier about the 6 levels and seeing these as like the markers, which was a great way of describing it. And just before we started the podcast, we started saying, look, you see it as kind of like the GMFCS curves. Can you explain that thought for everyone?
Yeah, I think the terminology is quite hard to it's hard to express in a way that will be understood in the right way.
Sure.
Because we say they drop in intellectual level, but they're not actually dropping in their intellectual capability or functions. But they try to. It seems like they stop.
Yes.
And
they're not keeping up with the rest of the cohort who are continuing to improve.
Especially, I think, we see that in the age of 10, 11, and they are going from they are they have difficulties going up that step to an abstract understanding of the world, of things.
Yeah.
They stay on a lower level. They can't really follow in that phase.
Right. Yeah.
So in my mind, it's just a way of thinking. It's like the GMF-M curves for the different GMF-CS levels. Like if you have more of intellectual disability or some certain problems, maybe you reach the top in your development earlier, maybe at 5 years, at 8 years or 10 years, and then you keep that level. Yeah. And then you actually cross the lines for the different intellectual levels.
Yeah, that's a really good concept. I understand
developing like it's expected for the reference curves.
Right.
Yeah.
Is this going to be some future work for you?
Yeah, it would be very interesting to have this intellectual trajectories.
Yeah.
But also intellectual functioning is very complicated.
It is, isn't it?
It's the general level, and you have the visual, perceptual problems, executive problems, but it would be nice to have some sort of trajectory.
Oh, wouldn't that be wonderful? Because it does help to communicate.
Yeah.
It helps to track development and what is this expected or what that might look like. I mean, it'd be a great piece of work, Magnus.
And then you have to do things prospective.
Absolutely, yeah. So then you think about the complexity of these kinds of assessments. And these assessments are not just short, quick answer, here we go. They are comprehensive and they need to be, right? There's no shortcuts here.
In connection with the environment.
Absolutely, absolutely. Lots to think about there. I like that. And perhaps this will mean that we can keep talking about this over the years to come, Magnus. I can see that spark in your eye. This is what you'll be embarking on. So from your perspective, as both a researcher and as a clinician, what are you hoping that this work will shine a light on or do for current practice?
Well, my main message is that you have to repeat assessment in children with cerebral palsy, not just once. In Sweden, we have the recommendation to do it before you start school. Yeah. But don't stop there.
Okay.
Do a follow-up.
Okay.
At least when they are 11, 12, something like that.
Yeah.
And keep an extra eye on the ones with epilepsy and cognitive impairment.
Yeah.
And as a thing, you could actually focus on communication. I think that's a way of trying to improve the possibilities for children to develop.
Yes, expression and looking at AAC, different methods for really promoting that and thinking about their cognition. Wonderful.
Yeah, and both high technology and low technology.
Yes, that's right.
Because you have to have it in all situations.
That's right. No, that's a really wonderful message. Thank you, Magnus. That was wonderful. I love that conversation with you.
Thank you so much.
Thank you. And to all of our listeners, I hope you really enjoyed that too. That was a great conversation. Stay tuned for more, though. We've got more of the conference to come. See you later. Bye.